Hello and welcome to our What's New in Research and Treatment webinar, brought to you by Zero Prostate Cancer. My name is Jeremy Patch, Director of Patient Programs and Education here at Zero, and I'll be serving as our webinar host. I want to thank our featured speaker, Dr. Yaw Nyame, for sharing his time and expertise and giving us an overview of the exciting information that came out of the 2024 ASCO GU conference and the American Cancer Society report. Before we begin, I'd like to go over a few housekeeping items. Today's webinar is being recorded and will be posted on our website, zerocancer.org, later this week. As soon as the webinar ends, you'll see a link to a survey, and we would love for you to participate so we can get your feedback on this event, as well as an opportunity to share topics you'd like to have covered in future webinars. Tomorrow, you will also receive an email with a link to the video recording and the survey. First, I want to give a quick overview of Zero and what we do if you're new. Zero Prostate Cancer is the leading national nonprofit with a mission to end prostate cancer and help all who are impacted. Zero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. Zero is proud to offer a variety of patient support programs and educational tools, all of which are free to patients and families. I'd like to spend just a moment highlighting a few of them. 0360 is our comprehensive case management program that provides support to help patients and their families connect with financial assistance programs, navigate insurance, and find other kinds of support, including emotional support and transportation assistance. So if you have questions or need resources, call our 0360 helpline. We offer 2 peer-to-peer support programs. Our mentor program makes one-on-one connections, matching patients with survivors who want to provide emotional support. We also offer peer-to-peer support through our Zero Us 2 support groups. Please take a look at the support group finder tool on the Zero website to find a group near you or participate in a virtual support group, which there are many. And if more about virtual support, you can also connect with prostate cancer patients, survivors, and caregivers in Zero Connect, which is our private Facebook group. We also host a prostate cancer community on Inspire, an online patient forum with more than 30,000 community members. So these are good avenues. If you have questions, want some immediate support, you can go on those and ask some questions and have people who've been through the experience provide those answers for you. I want to personally invite all of you to our virtual education summit that will be happening next week from March 12th through the 14th. This event is free, and you will hear from experts as they discuss treatments, side effects, genetics, and more. We are also offering a handful of virtual support groups as part of the summit. Even if you can't attend during the scheduled times, no worries. All sessions will be recorded, and if you register, you will receive information on how to access these recordings. The registration link will be shared in the chat as well as in the follow-up email from this webinar. Now it's my pleasure to introduce our featured speaker, Dr. Yaw Nyame, a surgeon, researcher, and educator in the Department of Urology at the University of Washington School of Medicine. Dr. Nyame will share exciting updates on prostate cancer research presented at this year's American Society for Clinical Oncology Genitourinary Conference, otherwise known as ASCO GU, much better to say, as well as share insights into the American Cancer Society's 2024 Facts and Figures report, which included some alarming statistics on prostate cancer. We will take questions from our audience at the end, so please feel free to type your questions at any time in the Q&A box located at the bottom of your screen. We will do our best to answer as many questions as we can. So before we get started on our discussion, I did want to turn it over to you, Dr. Nyame, to just hear a little bit about your research and what you're doing with the Backpack program.
Jeremy, I just want to say thank you for this invitation. Thank you to Zero for being such an important partner in the work we do here at the University of Washington Fred Hutch Cancer Center. As a researcher, I'm a health services researcher. And a lot of the work that I do is really focused around how we improve the quality of the care that we deliver. And there are multiple definitions that are used to define quality care. It's got to be accessible, it's got to be efficient, things that would make sense to anybody. It's got to be timely. But I think one key component of quality care is equitable care. It's got to be equitable. And so in 2020, here in Washington State, we formed an organization that really was looking to partner with Black prostate cancer fighters and survivors to be part of our research team in conducting work. I was very lucky to have a talented person on the team come up with a great name, Backpack. So that stands for Black and African Descent Collaborative for Prostate Cancer Action. I wish I could take full credit for Backpack, but I did not come up with that name. And the group has been meeting over the last 4 years in various capacities to do research together. And we have a platform that allows patients to be natural partners. We have actually over 30 advisory members on research projects that are ongoing here at the University of Washington. And if you go to the next slide, what you'll see is that our work really is collaborative. We really believe that reciprocal relationships, cooperative learning, partnership, and I think this last bit, transparency, honesty, and trust is what's needed for equity, not only in the care we deliver, but in the research that we do. And we're really fortunate to call Zero one of the many partners that we have in this work that we do. So currently we have a research project ongoing that is funded by the Patient-Centered Outcomes Research Institute, more commonly known as PCORI, a little bit easier to remember. And what we're doing is a survey among Black prostate cancer survivors and their caregivers to understand what research priorities they want us to tackle. We're really lucky to have 8 survivors that are part of our research team that are helping us direct this project specifically. That includes Marty Chikoyan, who is one of the key members of Zero leadership around support groups. And so this is a really exciting project. There's a QR code here that you can see on the screen that gives you an opportunity to join our virtual research community, which is a way to access this particular survey. We're providing a $20 compensation for completing the survey, and we encourage anyone who's interested in having their voice be part of the next phase of early detection prostate cancer research to consider doing this survey. So with that, I'll turn things back over to you, Jeremy, and I thank you for creating this space for us to talk about an important project around equity in prostate cancer screening.
Yeah, well, thank you for giving us that overview and for doing this important work. And we're happy to partner with you on it. So, well, let's get into our discussion. We did promise we'd talk some about the ASCO GU findings and the ACS report, so we will dive into that now.
Sure.
The ASCO GU conference occurred at the end of January. It occurs annually. One of the conversations to come out of the conference was new screening recommendations for Black men. Can you tell us more? And this, I feel like, connects very well to your research and what you were just talking about, right? Can you tell us more about those recommendations?
Yeah, so the Prostate Cancer Foundation submitted a abstract to the meeting. It was accepted as a poster, but I thought, it was one of the really intriguing and important pieces of research that was shared at the meeting this year. As many of you know, Black individuals in the United States are at a higher risk of developing prostate cancer. We estimate somewhere between 50 to 70% higher risk, and more than twice as likely to die from prostate cancer. We've done some research in our group in a study led by one of our medical students at Drexel University, Nana Frimpong. And Sarah Holt, one of our biostatisticians, that shows that we've lost about 1.5 million years of life due to prostate cancer among Black individuals over the last 50 years. And so these guidelines are really important. They came under the leadership of Isla Garraway, who's a urologist at UCLA, Sigrid Carlson, who's a public health researcher at Memorial Sloan Kettering, and William O, who's the chief medical officer at the Prostate Cancer Foundation. And the group got together 19 clinicians. I was very lucky to be one of those clinicians, and 3 patient advocates who served as an expert panel in addressing 6 key questions. I think what was really lovely about this effort was that the panel didn't just include urologists or radiation specialists. It had medical oncologists on the panel. It had primary care physicians on the panel. So it really was a multidisciplinary panel. And again, this understanding that the patient voice is so critical for all of the endeavors that we take. So to have 3 fighters and survivors be part of this panel was really fantastic, and allowed for really rich discussion. And I think 6 guidelines that really 6 guideline statements that really capture the essence of the need for screening among Black males in the U.S. Excuse me.
And can you tell us a little bit more about those guidelines and what they say about the ages? So we know this has been debated for a while now. So can you offer any clarifications?
Yeah, so the guidelines essentially answered 6 key questions. So 1, should Black men in the U.S. be screened for prostate cancer? Number 2, what should screening look like? How should it be conducted? 3, what information should be made available? 4, what age should someone obtain their first PSA at, and how often should they have testing? 5, what age should we stop screening at? And then 6, how do we address those who have strong family histories or genetic risks that self-identify as Black in the U.S.? And so I think each of the statements like address this, and I think they did so in a really clear and concise way. The leading group on the research side for this study did what we call a review, a systematic review, meaning they went through the literature and they really carefully looked at what had been published and tried to put all of that information together to have the best evidence basis for the statements that we made, so that it didn't come down to how strongly I felt about one thing or somebody else on the panel, but we were using the evidence to really support what we did. And so the statement 1 was really that we need to recognize that Black populations in the U.S. are high risk for prostate cancer, and they deserve to have a shared discussion about the benefits and harms of screening. The abstract also wanted to really clearly state that what screening was, and that the PSA test was really important, and that the digital rectal examination, although a key component of staging when we diagnose people with prostate cancer, was not necessarily an effective tool. And if it was going to be something that deterred men from going out and getting screened, that we really needed to de-emphasize its importance and the role of screening. And this actually was part of the discussion where I say we learned a lot as a group, because there were different opinions across the room, including among some of our patient advocates who had really invested so much into going into the Black community among their peers and saying, you know what, don't fear the finger exam, so to speak, and go get screened. But I think when we were able to share the evidence collectively as a group, even those individuals who had invested so much of their life into this idea of getting everyone to understand and not be fearful about screening, especially when it came to the rectal examination, agreed that, you know what, there was no need to make that a deterrent and to really rely on the PSA testing. And then to answer your question directly about when to screen, and how to screen. It really was, we had two statements, one around starting earlier. So if 55 was a age range provided by some of our former guidelines, like the U.S. Preventative Service Task Force, this guideline states screening should be considered at 40 or 45, at least obtaining a baseline, and then tailoring frequency of testing based off of what that PSA shows. And we had actually talked about in the guideline annual testing for those that were truly high risk based off of some of the evidence produced by our group here at the Fred Hutch under the leadership of Ruth Etzioni. And then stopping once life expectancy started to become less than 10 years. And age 70 is used in the guideline, it's used in the literature. I do think the guideline statement recognizes that age doesn't need to be the strict cut point from when you stop PSA testing, because there may be benefit for some men that are well over the age of 70.
Okay, thank you for providing that overview. That's helpful. And I think this is really important for Black men to be aware of this so they can have this discussion with their doctor. And that kind of leads me into the next question, which, most men, men are notoriously bad for getting annual checkups and going to the doctor. But their encounter is usually going to be with their primary care physician. So how can we ensure this conversation carries over from urology, oncology to primary care providers?
Yeah, Jeremy, I think there are a few ways that happens. One is in the way that a guideline like this gets put together. Again, I really emphasize that we had all the key individuals that are involved in this process at the table. And I think when you have primary care doctors that are able to voice their concerns and be part of this process, that you have and that are leaders in their field, you have natural champions to go out to the rest of the primary care workforce to say, we should pay attention to this. Number two, this paper is currently under review in a really, really high impact journal and making its way through that process. So these guidelines will hopefully be published in a form where everybody has a chance to review them, scrutinize them, but hopefully also apply them. And then I think forums like this where we talk about the latest guidelines on what to do, the shared decision is a two-way street. And the more we can arm community members with good information and clear guidance on how they should pursue screening, the easier it is to engage in that two-way conversation with your doctor, right? And so I think making sure we get these guidelines disseminated widely and in a wide number of forums where people can digest them is really important.
Thank you for that. That's good. Now we will shift to another conversation that occurred there as well, which I think is also equally as interesting. And that conversation that occurred at the conference was centered around the debate of whether low-risk prostate cancer should be renamed. Yeah. Can you tell us more about what that debate is?
Yeah, I think we've seen this debate come to the forefront over the last few years, really championed by Scott Egner, a urologist at the University of Chicago, and some other urologists across the country. There's a strong patient advocate component of this group now. You've had some pathologists also come into the discussion. Part of the scrutiny around prostate cancer and especially prostate cancer screening is the concern that we're going to find what we term clinically insignificant cancer. What a terrible term. But this is this idea that there are some cancers that we would be better off not finding because they just don't have the potential to cause death, right? Or to impact someone's natural life. And so there's been this group across, that has been really vocal about the need to really assess what a Gleason 6 or a grade group 1 prostate cancer is. And if you look at the way that it behaves biologically and clinically, it doesn't seem like these low risk cancers really have lethal potential. By and large, these are slow growing, maybe abnormal cells and clusters of cells, but they don't seem to drive a lot of bad outcomes for people. And so, should we rename this from its current classification of cancer to something else to suggest that this is an abnormal cluster of cells that has abnormal look under the microscope, but clinically to not give it the name cancer, which implies aggressiveness, the potential to cause spread, and more importantly, the potential to kill people. And so that is the debate. It was front and center at this year's meeting. And we had two, really experienced urologists have a debate, literal debate, a pro and con debate at the meeting, which I think generated a lot of important discussion.
And where do you see this conversation? How do you think it will continue or progress in the future? And then second part of that question, you can answer them separately or together. Should we expect any changes in practice?
So, should we expect any changes in practice is probably the easiest one to answer. I don't know, because I think if you look right now at the debate, it's and this is going to get sort of home to my big takeaway, and maybe this is because it's the type of research I do, right? We do patient-centered research, so I think there is a bigger need to understand what a renaming or relabeling from cancer to non-cancer will mean for patients and their ability to make decisions about their lives and their health care, and whether or not that's something that's important to them. And I think we're starting to see some studies do that. Dr. Egner, who I mentioned earlier, did a study that was published last year that showed that about 17% of the time changing the name from cancer to a non-cancer label would push people to choose observation. And right now in the country, we do still have a problem with people who are diagnosed with these low risk or favorable cancers getting treatment. We call that overtreatment. So maybe the renaming will drive more use of non-treatment. But if you look in the active surveillance literature, we know that about 50% of people who have low risk cancer, maybe more if you believe the PROTECT trial results from the United Kingdom. So anywhere 50 to 65% of people are going to require treatment over 10 to 15 years. So the proponents of the relabeling would say, well, if I tell somebody they don't have cancer, maybe they're just going to not worry about it and get all the additional follow-up that they require because, you know what, I don't have cancer. I'm good to go. And they may find themselves being in that group of individuals that develop a more aggressive cancer or harboring a more aggressive cancer that, only gets detected with the repeat PSAs and the biopsies in the future that really do deserve to be treated. So it's a hard question to answer as far as do I think the change will come, because I think the debate is still ongoing. I think until we really answer this question, what do patients, what do survivors, what do people who are at risk of developing this cancer think? Is that name change meaningful to them? Is it important to them? How would it influence their decision making? Till we really answer that, I think that we're losing the opportunity to make a change one way or the other that has positive impact. So I think that the people leading this debate understand that. There's a lot of ongoing things that I think are going to drive the opportunity to get better information about this debate. But there is no doubt that we have, strong contingency that says, why put people through the anxiety of a cancer diagnosis for a cancer that doesn't seem to spread, doesn't seem to cause a lot of prostate cancer death? And by the way, when we give this label, we tend to treat people that don't need treatment, and there's a harm associated with that. And then I think there are proponents that say, well, technically it's a cancer, right? It has all the features when you look under the microscope. And, let's not forget that a lot of people who have these low risk cancers do require treatment over the long term. But man, if I gave you the list of names that are being considered, I don't know. Are these things neoplasm of low malignant potential, indolent lesion of epithelial origin? I don't know if people have I don't know if I have an understanding of what those terms are and how they would affect my own decision making. So let's just say this. It was a very well covered and spirited debate. The two debaters remain, good colleagues, and I think everything was really congenial. But at the end of the day, I think there is no clear answer on where we're going to settle as far as this particular topic goes. So I think for the patients on the webinar today, just be aware that this is a topic of discussion because it could affect, people very much in your networks, people like you. But also because this debate is ongoing and we're not always including your voices, I think when you have chances to talk to researchers, doctors in your communities, this is a topic to bring up because I think we're all curious to know more about what your feelings are about a name change that would essentially remove something like 30% of current cancer diagnosis out of our cancer statistics and diagnoses. It's not a small number.
Right. Thank you for that overview. That's kind of a helpful take on the conversation and where it might go. Was there anything else relevant to prostate cancer that came out of the conference that our audience might be interested in?
Yeah. In preparation for this meeting, Jeremy asked me, like, what were the big things from ASCO GU this year? I said, Jeremy, it was not a big prostate cancer year for ASCO GU. And the way this meeting goes, it's very cyclical. This year was a good year for bladder cancer research and kidney cancer research, but a little bit less prostate cancer. So there's really one study that I wanted to highlight. And it's in a topic where I'm not a specialist. So I'm going to talk about it at a very high level for that reason. But there was the GITUG AFU 18 study. Say that 3 times fast. And it's a radiation trial that looked at 2 different types of radiation combined with hormone blocking therapy in high-risk prostate cancer patients. And if you look at the history of radiation, we have increased radiation doses over time because of their efficacy in treating prostate cancer. And typically, we give somewhere around 71 gray of radiation dose for prostate cancer, somewhere in that ballpark, sometimes a little bit more. Again, I want to be careful as a urologist to not speak out of turn. But this trial looked at a 70 gray radiation dose versus an escalated dose to 80 gray in this high-risk population. And they reported long-term outcomes at the meeting. The study had 500 patients, and it was started in 2009 and stopped enrollment in 2013. So when I say long-term outcomes, yeah, we're talking about over 10 years of follow-up for those who finished the study. And what they showed was that it reduced recurrence or progression. So those are two things that we care about, right? Those PSA numbers going up, or a subsequent scan showing new cancer. It reduced that by about 40%, a little bit over 40%. So that's not trivial. And it improved cancer survival by about 50%. And so those are not small differences in the two main outcomes that we tend to track with the increased dose of 10 gray, so moving from 70 to 80 gray. And
Yeah,
I think the natural question for anybody, myself included, is, well, if you're giving more radiation, are you doing more harm, right? And I think that maybe the biggest punchline to me was that this increased dose in a selected high-risk population, high risk based off of the Gleason score or PSA, that increasing the radiation didn't seem to increase the side effects. And so I do think you're going to see more men who are diagnosed with high risk prostate cancer that are choosing radiation get this higher dose, because we know there's a benefit, and the benefit to harm ratio doesn't seem to be in favor of harm, but it's definitely more in favor of benefit.
yeah, that sounds promising. With,
Yeah.
like you said, thank you for pointing out, because that was going to be my question, but you covered it for me. I was going to ask about the toxicity, but you covered that, so thank you.
Yeah.
Well, that's good. And then, well, maybe we can hope that next year will be a big prostate cancer year at ASCO GU.
What I've come to take away from the meeting is if we have a lull in one, cancer sites reporting, that you can almost guarantee that the following year they tend to come in with those really informative big studies that change what we do or augment what we do. So last year was the year of things like triplet therapy and PARP inhibitors in the castration-resistant space, things that changed guidelines. And so naturally, this year was a little bit quieter. So we'll see what next year and the year after have in store for our patients.
Great. Can you say that study, though, the radiation, just in case our listeners wanted to go look it up more
Yeah.
or mention
So
it? Yeah.
it's a European study, French, I believe. So I think it's GETUG, GETUG AFU 18.
Okay. We got to talk to people about these study names, but it's French. It's okay.
Yeah, I'm sure my any of my peers who see this might correct me if I am at the end of the day a simple Oklahoma man. So hopefully I came close.
Okay. Well, thank you for that. Another thing that we said we would talk about is in January was the release of the American Cancer Society Facts and Figures report. They come out with this every January. But in it, we learned once again that the number of patients being diagnosed with advanced prostate cancer is continuing to increase. Can you tell us what might be causing this rise in
Yeah.
advanced disease?
This is a tough question for a wide number of reasons. But what we've seen is year over year, since about 2011, that there's been about a 4 to 5% increase in the number of advanced prostate cancers. And I think we've seen that the number has really increased. I said 2011 is when we started to see that trend, but in more recent years, that increase has been more persistent, especially in the metastatic setting. The simple answer is that we think that there is a correlation with screening. Certainly, we see that trend starts to uptick a few years, 4 or 5 years after the 2012 recommendation by the U.S. Preventative Service Task Force against screening in 2012. But that guideline was reversed to a certain degree in 2018, and we still see that increase occurring. it's hard to understand how much screening has contributed to that, although we have some studies that show that changes in screening definitely would lead to the kind of change we've seen in metastatic cancers. But I don't think we can attribute it all to screening. And so the question then becomes, do we have more available technologies to detect prostate cancers, like better PET scan type technologies, more CT and bone scan availability? Um, and so we don't know how much of that is contributing to the statistics as well, because it's unlikely that this is all explained by less amount of PSA testing in the community.
Well, thank you for that overview and response. Yeah, any final thoughts on just prostate cancer numbers or statistics? You know,
Yeah.
yeah,
So I do think the statistics are important. You know, the American Cancer Society, as you said, produces this report every year, and their estimates for new cancer diagnoses among men in the U.S. is 299,000. So that number keeps going up. A couple of years ago, it was 275,000 was the estimate for a number of new cancer diagnoses. And prostate cancer remains the second leading cause of death from cancer among men in the US. So there is still a lot of work to be done and a lot of opportunity to make sure that we are supporting folks that are diagnosed, that we're getting them the treatments that we know they're effective. And I was talking with a colleague yesterday about this, and especially with regards to screening, because when it comes to screening, you have to have the opportunity to benefit. And the natural history of prostate cancer, which occurs over 8-9 years before we reach these levels where maybe we can't cure, gives us tremendous opportunity to intervene. And I think that the field, urologists, radiologist, medical oncologist, radiation oncologist, we've all made so much progress in how we detect cancers with real efforts to try and not find those cancers that we don't need to find, to not treat those cancers we find that are low risk or favorable risk, and really to try and maximize the opportunity for benefit. And so I think it's really important that and I include all of you survivors and fighters in this, we and caregivers, that we continue to have this discussion about the harms and benefits of early detection and screening, because this is a really common cancer. 1 in 8 men over their lifetime. If you have family members that have had cancers, not just prostate, but breast, ovarian, colon, if you are of African ancestry, that might be 1 in 6, or 1 in 6 lifetime risk. So these are really important to remember, and I hope that these statistics are something that we continue to look at. And when it comes to inequity, this is kind of what we do and what I do, that we continue to also look within those numbers at the groups that are disproportionately affected, to make sure that we can bring down this burden as low as we can. I think the holy grail, what we're all looking for in the research, is seeing these cancer death numbers be very low, 0. And so I think we continue to work towards that as a group, and that's my big take home from all of the numbers reported this year. Still have a lot of work to do.
I agree. So I want to thank you for that. That was a great discussion and overview of some really important things. I also want to get to our audience always has great questions, and I want to get to a few of those. One of my favorite questions on here is, I think we highlighted your work We talked about the screening for Black men and the greater risk that they face. And I mean, I've only been in the prostate cancer space for 2 years. And it's clear that we've been talking about this far before I joined Zero. So I think we've gotten, we can get used to it. But this question is, and we shouldn't get used to it. We need to continue to have these conversations and highlight it. But I love this question is, why do African American men face the greatest risk of prostate cancer?
Yeah, the simple answer is we don't know, right? And I always think about this problem as a multi-factor issue, because certainly prostate cancer has a genetic basis, and regardless of your race, ethnicity, we think about 50% of prostate cancer is explained by your genetics. And certainly within certain populations of African ancestry, we see some genetic susceptibility that's unique to the population, but that certainly doesn't explain all of the extra prostate cancer that we see in the community. So that gets a lot of us, myself, and a lot of people who are interested in this space thinking about the interplay between structural factors that are correlated with race and social factors that are correlated with race, and how those interact with the biology. And that's really complicated. And I think it's hard to study what the biologic impact of things like racism are, right? And those are the things that we really are starting to try and investigate and understand better. Is it diet? Is it obesity? Is it high blood pressure? Is it all these other health factors that can be disproportionate in certain communities, like the Black community? So this has been a known fact for over 50 years. I hope that we're starting to get closer to answering that question directly. I look forward to a time where I can say, well, 30% of it is explained by this, 20% by this, 50% by this, but we're not there yet.
Thank you for that. One of the questions kind of goes back to the screening conversation. So, and the question is, digital rectal exam, not effective because not a good predictor, or refusal of people to have it?
Oh, great question. Well, the digital rectal exam has some subjectivity to it. And we've actually seen this in a lot of physical exam tests. So you would think the stethoscope, right? Cardiologist puts it in. They've all been practicing for 20 years. They all hear the same thing, but no, they don't. There's a lot of variation that reflects experience, and other things. And we see that in radiologists, right? Radiologists been practicing a long time. They all look at the same X-ray. Do they see the monkey that's hidden on the X-ray, or gorilla's face that's hitting on the X-ray? Quite a few of them miss it because they're not looking for that. So the digital rectal exam is just not effective because there is variation in expertise and experience. And truthfully, a lot of people are getting screened really early on where they don't necessarily have a nodule that we would find. And now we have PSA and MRI, other tools that can help us find the things that we may rarely find with the finger exam. So it's just, it's not a very effective tool for screening. Now, once you're diagnosed, I think it's a critical tool for understanding how aggressive your cancer is. So two different applications of the test, and in one, I would say you don't necessarily need it up front. You may get it if your numbers are abnormal. You'll definitely get it before your biopsy, so we can incorporate information from it. But I think as the first thing you get for cancer screening, I personally feel like it has low utility based off the literature. I just want to be clear. That's not my personal opinion, but just based off of a review of what's available and all the studies that have been done to date.
Okay, great. Thank you. There is a question too for that study name. And And I'm going to type this into everyone just because, I asked you to repeat it, the radiation study, but I'm going to type it as you into the chat so everyone kind of sees it too, because
Yeah,
it is a tough one. So what was that again?
I'm doing it right
Oh,
now.
great. Make sure you're set to type to everyone. You got it. Okay. Thank
All
you.
right.
Appreciate it. All right. So were there any conversations, I believe at ASCO GU, on the outcomes of using PSMA, lutetium-177 treatments since it was approved by the FDA?
Yeah, that discussion happened last year. As you know, there are well, you should know that there are many ongoing studies of the lutetium PSMA agent. Studies, the way that these studies occur is that we typically start them in the highest risk population, which tends to be our castrate-resistant population, and then we bring them earlier and earlier stage. So I know that there is ongoing study in the hormone-sensitive space and even in the high-risk localized space. And I look forward to those results being shared with us at future ASCO GU meetings.
Thank you. Here's just a question. How do you define advanced prostate cancers?
Great question. So there are two labels that we tend to use for advanced. One is regional and the other one is metastatic. The easiest way for me to think of advanced is not confined to the prostate. So if it's in lymph nodes and the pelvis, that can be considered advanced, and that would be in that regional category. So pelvic lymph node involvement. And then metastatic obviously is anything that's spread outside of the pelvis, as far as organs go, or spread to the bone. So that advanced category sort of captures everyone that's in there.
And regional, another name for that, correct me if I'm wrong, is locally advanced.
That could be also be termed locally advanced, although locally advanced also could mean spread from your prostate to the bladder or to the seminal vesicle, maybe, depending, or extra prostatic extension. That's why we talk about the finger exam being so important. So those terms, unfortunately, get used interchangeably sometimes, and it's hard to categorize it. But that's the reason why I try to use the term advanced to just signal those are the cancers we know that have the potential to have impact on natural life for our patients.
Thank you. Just going through the questions here, we'll do a couple more.
Sure.
Any news on monoclonal antibody or laser therapies for low-grade cancers?
So, no, not that I know of. I think a lot of the immunotherapies that we're looking at are mostly investigated in the metastatic setting. So there are some conjugate, not to get too technical, but there are some immune therapy targeted therapies that are binding multiple sites and trying to really target specifically immune agents to prostate cancer. But those are all not in the low risk setting. And then when it comes to laser therapy and focal therapy, which I believe you're hinting at, I think I have a hard time being a strong proponent of treatment for low risk prostate cancer when the standard is to watch it.
Right.
So I think and it makes the results murky, right? If you tell me that a laser or high intensity ultrasound or electroporation, some of the therapies we have available now is just as good as doing nothing, and I know nothing is a really appropriate treatment, I'm not sure how to interpret that. However, in patients who have more aggressive cancer, I think that's really that frontier where if someone has a small amount of cancer in a specific spot in their prostate, that things like the laser therapies, the focal therapies, really stand to have that provide us that benefit, and especially if it can reduce some of the harm of our treatments.
Can you discuss the use of MRI for early detection?
Yeah, it's a great question. I'm a big proponent of MRI. I think the best randomized study we have to date is a trial called the Göteborg 2 trial. Göteborg being in Sweden. So if you're looking for that, you type GOTEBERG, excuse me, trial and MRI. And it was published in the New England Journal last year. And what they looked at was what the role of MRI targeted biopsy only had on the detection of prostate cancer. And suffice it to say that when they randomized two groups to MRI only targets and standard biopsy plus MRI target, that they were able to reduce the number of extra prostate cancers that were, quote, low risk, or again, I don't like the term, but clinically insignificant by about 20%. And so it's a meaningful reduction, and they did so without necessarily incurring a lot of extra any meaningful missed cancer diagnoses over time. And so I do think that there is a strong role as we move forward with in early detection of considering the role of MRI in detection, just because the benefit is so significant. I think I said 20, but it's 50%. So it's a really substantial decrease overall in finding those cancers we don't want to find. The other benefit, I talk about this all the time, I know you're about to ask a question. The other benefit that I think is not trivial is you get a lot of additional information about the prostate from the MRI. The issue with MRI is the cost, right? And especially, we don't want to order tests that hit the pocketbooks of our patients if they're not going to add a lot of value. But sometimes the MRI is what lets me know somebody has a really big prostate and just needs a simple TURP procedure rather than their whole prostate removed. So there's other benefits to it. I think if we could lower the cost of MRI, it would be a no-brainer for most primary care doctors and urologists to order that as the next thing to do when we find that your PSA is up. But I think sometimes we have to wrestle with the financial impact of ordering that test in our decision making, unfortunately.
Okay, thank you. I saw another one is what is castrate-resistant prostate cancer?
What is castrate-resistant? So the terminology changed, and we actually are trying to use hormone-resistant more than castrate-resistant. But this is the idea that when you have metastatic prostate cancer, our main way of treating it is by blocking testosterone. That's what androgen deprivation therapy is, or ADT. I always say we block your testosterone because I think that's easy, much more intuitive way to think about it. We block the production of it, and we take that away. Now, at some point, metastatic cancers that have are in the environment of testosterone blocking we'll start to figure out ways to grow in this environment where there is no testosterone, which is typically a primary fuel for prostate cancer growth. And when you get to that point where the testosterone blocking is no longer effectively controlling the prostate cancer, that's when we have historically used the term castration resistant. Now we use hormone resistant as well, as a reflection of the fact that now the cancer seems to not be dependent, or you'll hear hormone independent prostate cancer. So it's so many terms there, and I think we're trying to be thoughtful in the way that we phrase them for a variety of reasons. But that was a really long answer to a simple question.
Okay. Well, thank you. Well, there are a lot more questions here that we do not have time to get to. I see on genetic testing, and I just want to remind everyone that next week, again, March 12th through the 14th, we will, I'm probably getting ahead of my script here, but we will have our virtual Zero Summit. And one of the topics testing, there's an Ask the Expert Q&A feature discussion, kind of like this was a discussion today. We'll have an Ask the Expert one, and based off of questions that the audience submits previously. So if you have questions that you would like to see covered, you can email education@zerocancer.org or our experts during that time. But more importantly, register for the virtual summit so you can hear these either live. We also have on-demand videos, and even if you can't make the live sessions, you will, by registering, you'll get emails about the recordings and when they're available. So there is that information. So much more information. We talked about just, the tip of the iceberg today on some of this. And so come next week and get all of that information, or a lot more information. So I want to thank you so much, Dr. Nyame, for joining us today, for going over kind of what the findings and discussions were at ASCO GU. I think it's important that our community keeps a finger on the pulse of what the conversation is from experts. So thank you for giving us an overview of that, and just also for your work on Backpack, which people can, we dropped information into the chat earlier on Backpack, so people can go to that website and learn more. Yeah, just very, very appreciative of your time and expertise today. Thank you.
Well, Jeremy, thank you so much for having me join the group. These are the things that I get to do outside of my clinical work and research work that really is fulfilling. And so thank you for the invitation, and I look forward to more opportunities to engage with your survivor network at Zero.
We hope so. Thank you. As we close, I do just want to remind you to please fill out our short survey, which has been dropped into the chat as well. You'll also receive an email with that survey link, and where you can find the recording of today's webinar. Thank you all for joining us, and I hope you have a wonderful day. Take care.